My evidence-based practice presentation, assignment part 3. My name is Cami Keogh, and it is spring 2024. My topic of interest for the evidence-based practice assignment is induction of labor outcomes, particularly emergency cesarean section births. The area of focus is in the clinical setting. And why does this topic interest me? This topic interests me for one, because I am expecting in August my first child. And over the past couple of years working at William B. Ryrie Hospital, I have noticed that a lot of labor inductions seem to end in emergency cesarean birth outcomes. And so I wanted to take a deeper dive into one particular intervention and see if there was any difference in that intervention and how it's administered, misoprostol, and compare the outcomes of that. So my PICO framework, my patient population is antepartum patients who undergo induction of labor resulting in emergency cesarean births. Intervention is administration of misoprostol for the purpose of cervical ripening in labor inductions. Comparison is to compare the efficacy of vaginally inserted misoprostol versus oral misoprostol. And outcomes. I will evaluate whether administration of misoprostol vaginally or orally is more effective in successful labor inductions, and which of the two routes, if either one, decreases emergency cesarean section births. So my question is, does the oral or vaginal route of administration for misoprostol affect the success of induction of labor and thus decrease emergency cesarean births? So here is a graph from Statistica. It is from 2024 with data collected in 2023. So percentage of mothers who had select reasons for their cesarean births in the United States. As of 2023, the graph shows that between emergency cesarean unplanned before labor and emergency cesarean unplanned after labor had started equals 44% of cesarean sections. So the first study that I did was labor induction with orally administered misoprostol. So the summary of this study, it provided me with evidence that addresses oral administrations and the effects of PO misoprostol and what it has on maternal health outcomes. The sample size for the study was 4,002 singleton pregnancies with gestational age at or above 34 weeks gestation, years 2009 to 2012 and 2012 to 2013. When the maternal patient was administered misoprostol PO as a solution to drink every second hour. And the outcome of this was the proportion of emergency cesarean sections decreased from 26 to 17% when orally administered misoprostol was introduced. After adjustment for different risk factors for cesarean section, the only method of induction associated with cesarean section was dinoprostone. And dinoprostone is a different type of prostaglandin. So the study I did was the comparison of cesarean delivery rates after 3 methods of cervical ripening among obese women at or after 41 weeks. I liked this study because there were a few more parameters to the population that was being studied. So a BMI at or greater than 30, and the maternal patients were also at or beyond 41 weeks of gestation. The sample size of the study was 336 women in total. This was performed in French maternity units, 2 multi-center randomized control trials. And the 3 methods compared were vaginal misoprostol, vaginal dinoprostone, and vaginal double balloon catheter. So the conclusion of this study was essentially no cervical ripening method showed better efficacy for decreasing cesarean rate among obese pregnant women at and after 41 weeks of gestation. Furthermore, perineal tears or episiotomies were actually significantly lower if dinoprostone was used in comparison to misoprostol. Neither method was conclusive of lower cesarean rates in obese women in this study. So I liked this study and I wanted to include it because although it does not address oral versus vaginal misoprostol administration, I still wanted to focus on the safety component and the risk factor of the perineal tears and episiotomies with dinoprostone versus misoprostol. I found that interesting. The third research article that I wanted to include is probably most specific and pinpoints to what I was trying to discover with my efforts of research. So the efficacy and safety of oral and sublingual versus vaginal misoprostol for induction of labor. The summary is this piece of evidence investigates and describes the efficacy and safety of oral misoprostol in comparison to vaginally inserted misoprostol for induction of labor. This study consisted of 10,975 parturient, which means females in labor or about to give birth. These maternal participants were administered misoprostol with the therapeutic intent of cervical ripening for induction of labor via oral, sublingual, and vaginal routes. The conclusion was that sublingual and oral misoprostol intake seemed to be more safe in comparison to vaginal administration without increasing the accompanying morbidity, and increasing the dose regardless of the route of administration with misoprostol does not seem to increase efficacy. Changes for clinical practice are to consider the individual antepartum patient's health profile. So as we've seen from one of the studies, patient weight, their gestational age, their pertinent health history, all should be considered when choosing a route of administration. Compare the patient's health profile to the presented research outcomes specific to their situation. 3, recommend for RNs after SBAR or select for physicians the most appropriate route of misoprostol administration for the specific patient. My research concludes and suggests PO or sublingual over vaginal, and keeping up to date with current evidence-based practices and literature regarding the safety and efficacy of misoprostol. To initiate changes are to review and assess the current protocol at William B. Ryrie Hospital for induction of labor, standards of practices. From here, we can identify current preferences and practices ordered and utilized by the 2 OB-GYN providers at William B. Ryrie Hospital. We'll trend that data over time and compare demographic profiles and outcomes to those of current studies, the studies explained, and implement changes in practice to benefit patients and decrease emergency cesarean rates, and evaluate the new changes and processes for effectiveness and improvement. So we're going to apply the nursing process to our steps for initiating changes. My list of who to involve with this implementation process is Pam Edzema, William B. Ryrie Hospital CNO, Nurse Wendy Finicum and Nurse Brandy Summerall. These are staff RNs at William B. Ryrie Hospital that are a little more specialized than some of the other nursing staff as far as obstetrics and labor and delivery go. Matt Walker, the CEO, Dr. Benham, OB-GYN, Dr. Tanner, OB-GYN, and Dr. Magosa, who is the William B. Ryrie Chief of Medical Staff, should be included. Thank you guys for watching and listening to my slideshow. And here are my list of references.